So first of all, thank you very much for the nice introduction, and I would like to thank the organizers for giving us the opportunity to bring us this very important panel discussion on diagnosis and management of respiratory allergies. And I would like to introduce my panelist. So Dr. Panagra is with me. He is a consultant pediatrician and allergy specialist and heading the Bengal Allergy and Asthma Center. Then Dr. Arif Ahmed, you have already heard from sir. So he is a very senior pediatric allergy specialist, and he is professor and head of the department at Shanann Medical College, Hyderabad. And he is also the director at Allergy Center for Allergy and Chest Diseases. He has got his specializations from UK and US and has got several publications and several awards. Dr. Mukesh Gupta, he is one of my colleague, very dear friend. He is the director at Jaipur Allergy and Asthma Solutions. He is also the treasurer of the IAP National Respiratory Chapter. And simultaneously, we also have Dr. Sanjukta Dey with us. So she is from the clinical director from Department of Pediatric and Neonatology, Peerless Hospital, Calcutta. She has also got several publications in national and international journals and has got her training in allergy specialty from United Kingdom. So let's move to the case discussion. We will be keeping a case in which we will be discussing, and Dr. Binayak Roy will be our chief discussant. So he will be having the liberty to chip in between or any expert comment any time which you feel, sir, you can just come with. So we will start with a case, a 7-year-old child, 40 kilo, Rahul. He came to us with coughing off and on for past 2 years, and there was some early morning sneezing and running nose which was there. So in this slide, what we understand here is 7 year, 40 kg, so there is a little bit obese child, coughing off and on for 2 years, early morning sneezing and running nose. After Dr. Paramesh sir lecture, I think the things have become much more easier. So the question to Dr. Sanjukta is, what else you would like to know in the history?
Thank you. And good afternoon, everyone. This is a child who has a long history of cough, but children can cough for long periods of time. So it's been seen that a child in a course of 1 year can cough up to 120 days in a year. So whether the cough is associated with other symptoms like nighttime awakening, snoring, a loss of school days, a lack of appetite. Here, lack of appetite doesn't seem to be a problem. And then whether there is any other systemic complaints like fever associated with the cough, and there is any family history of atopy or allergy. These are the things that are needed to be taken into consideration in addition to the treatment history, number of courses of antibiotics, whether inhalers or anti-allergics have been used at all, and for what periods and how, and whether any investigation was done outside. And it's very important to also ask about the sleep-related issues, whether the child is snoring, child is sleeping prone, because children with large adenoids, large tonsils with upper airway obstructions usually tend to sleep prone and also have mouth breathing.
So thank you, Dr. Sanjukta. So what we understand here is that everybody knows that every wheeze doesn't mean asthma, and asthma doesn't mean that every time it has to be associated with wheeze. The same story holds true even for rhinitis also, that every sneeze doesn't mean that it has to be allergic rhinitis, and every allergic rhinitis patient doesn't mean that he has to present with sneeze only. The other things which are important apart from the enumeration which Dr. Sanjukta has done is about how the child is going to school. This is very important. Which conveyance the child is taking to go to school, whether he's going through the bus, whether he's going to car, whether he's taking some auto rickshaw. If he's going through the car where the windows are rolled up or rolled down, if the windows are rolled up where the air conditioner is on or off, if the air conditioner is on, whether the mode of the car in which the air is getting circulated in to in or out to in. If the air is circulating from out to in, all the pollutants which are coming inside. So it's actually not working at that way. If the air conditioner is on, then at that time he is also getting some exposure to the humid environment, and that humid environment could be indicating us some fungal spores. This could be indicating some mites. So these all things are really important. Other thing which is important is the school where it is located, house where it is located, how far away it is from the main road. If it is less than 100 meters, more than 100 meters. More than 100 meters, lesser, you can say like exposure to the pollutants, study says, whereas less than 100 meters, so statistically significant chances, odds are nearly 2 to 3 times higher of the respiratory allergies, which is there. So in this particular child, the cough is who is asking, who is coming to you that, does anybody smoke? They always say, no, nobody smokes. Then they come out, oh, somebody is smoking at outdoor, nobody is smoking in front of the child. Is it safer? No, it's not safe. Why? If it's called as like a second-hand smoke. So if somebody is smoking second-hand or third-hand smoking, what they are doing is, during the time of smoking, the soot particles which are there, they are just getting deposited on their clothes. They are coming home. All the soot particles which they have got deposited, they are coming back to home and they are once again mixing in the home environment. So poor child is getting exposed. Other thing, we all are very religious people. We are using agarbattis, dhoop battis. Diwali is, I think, around the corner, 1 week down the line. So do you know that one agarbatti produces PM 2.5 particles equivalent to 85 cigarettes? Do you know that one dhoop batti produces PM 2.5 particles equivalent to 140 cigarettes? Nobody is smoking. And everybody is just using only single agarbatti or single dhoop batti. How much the poor child is getting exposed to those particular 2.5 particles, PM 2.5 particles. So which is important. And then regarding the pet animal, so they all are having a sentiments which is attached. So either they don't come up with the history that they have a pet animal, or they always say that no, I don't have a problem with the pet. I don't have a problem with the dog, because they don't want that the dog should be removed from their environment. And they already know, if they say, doctor will always say that remove the dog. So that's why. So these all are the factors which we need to really go in detail in the history. So you rightly mentioned about persistent asthma, moderate severe allergic rhinitis and obesity. So which points in the history points towards this diagnosis? I think you have already taken that. So which investigations you would like to do, Dr. Arif sir, and why in this case?
Okay. Thank you, Dr. Neeraj Gupta. You see, we have been discussing in the previous lecture also that allergic rhinitis is principally a clinical diagnosis. So now you don't need any investigation to say that this is allergic rhinitis. You have made a diagnosis. So the most important thing is the patient will ask you why, what is the reason behind it. So the next thing is to look for the allergens. And there are two ways of looking for the allergens. One is the blood test, the other is the skin prick test. Okay, if you can get the skin prick test, that is the ideal way of going about it. If you cannot, then go for the blood test, but by a proper method. The proper method is the specific IgE by the FEIA method. That is very, very important. And because you have a lot of laboratories which are been doing this specific IgE, and if your report comes with where the lab has tested for benzene and soaps and other things or drugs and all that, please discard that report, because these things cannot be tested. Now, which allergens should we look for? That is a very, very important question. So if you look at the history, if you go in detail through the history, clinically you can make out that this is basically dust mites, okay, because of the early morning sneeze. The next thing is, because of the dog in the family, you should think of dogs. And if dogs are around, the cat will always be around somewhere. So you also look for the cat. There is asthma, so you look for the pigeons. The next important thing is, because it's perennial, is cockroach is what you should look for. So these are the allergens. Now, what about fungus and pollen? From the history, fungus and pollen doesn't look like a possibility in this particular case. So the allergens which I mentioned, you should look for those allergens in this particular case.
Thank you, Dr. Ahmed. So as we all understand from the respiratory knowledge that in this particular case, or a child who comes to us with allergic rhinitis and asthma, so the first gold standard test will be spirometry, which everybody tries to do. So we are discussing now beyond that. So that's why Dr. Ahmed is discussing about all those allergy testing. So I'll come back to it. So let's say that this particular child comes back to you with a total IgE value of 600 IU per liter. As per the standard, it is high. So what are your comments about the total IgE values in diagnosis of respiratory allergies or any other allergy?
Yeah, that is the other very important thing, and it's a very good point you brought about. A lot of patients will come to me, my total IgE is high. And they'll keep monitoring, they're so taken up by this total IgE, they keep monitoring that total IgE. So I tell them very strictly, please disregard your total IgE. It has no value in my clinical diagnosis and in my clinical management. The only place that total IgE has a value in allergic rhinitis is ABPA, allergic bronchopulmonary aspergillosis. That is the only place. Otherwise, because 40% of your allergic rhinitis can have a normal IgE, and there are many other conditions in which the total IgE will be raised, okay? There are a whole list of conditions, including in our country, worm infestations and infections like tuberculosis and other chronic infestations. So, total IgE should be totally disregarded and should not be encouraged by either by the patient or by the practitioner to be done or to be given any importance in allergic rhinitis.
I would like to add some point.
Sir, please, sir. Yeah.
Thing is that the total IgE, there are several conditions where total IgE is high. So it is not specific, but only one case where we are prescribing for immunocap, the specific IgE, then it is some role, because if there is high level of IgE, then the chances of false positivity in specific IgE is also there.
Yeah, so we'll come back to this. So what we understand about the total IgE is, it is the most favorite test, right? Most favorite test, even by the patient also, by the laboratory people. Most of the time, majority of the time, patient come to you and says with a piece of paper, doctor, I am having allergy. Why you feel? What are the symptoms? My IgE is high. Why you got tested? Whatsoever the XYZ reason, but I have come to you because IgE is high. He is not speaking anything else, just came to you for a second opinion only because of high IgE. So this is considered to be equivalent to allergy, which is a wrong statement that we need to understand. Why? Rightly mentioned, total IgE can be high in many other conditions. I will keep you an analogy. A patient comes to you, a patient comes to me in my hospital, enters the hospital gate, asks the doorkeeper, I want to meet to a doctor. Doorkeeper can, you can say like direct him to anyone. He can direct him to pediatric, he can direct to gynae, he can direct to orthopedic, to a probably a BHMS, to a BAMS. Everybody is a doctor, right? It's like IgE. So IgE can be raised because of viral infections, post-viral, post-COVID, pollutants, pollution, allergies, n number of factors, parasites, HIV, n number of factors which are there, which can actually affect IgE values. So it is not having any relevance at all in either diagnosing or ruling out allergic disorder. This is the first step. Next come to, okay, now this particular patient says, no, I have to show my 3-year-old child. Now guard understand, oh, 3-year-old child, so it has to go to the pediatric department only. So now he has become a little specific IgE. Dr. Arif, so specific IgE, which allergen you have already mentioned about it. Can you please highlight a little bit about dust mite, because you mentioned a little bit more?
Yeah, you talked about the limitations of the specific IgE, and as Dr. Binayak has mentioned, especially in cases of atopic dermatitis, where because of the impairment of the skin and the reactants to the allergens, the total IgE is elevated. And because of the elevation of the total IgE, the specific IgE for different things will also be elevated. So that is, and it can give you a false increase in the specific IgE without any clinical significance. Now, what is the question about dust mites?
So question is about that, would you like to highlight a little bit about dust mite? You mentioned that dust mite is the most probable culprit here. So why you thought about it?
Yeah, so almost 60% of the cases will be dust mite, okay? And the 2 dust mites or 3 dust mites, that is Farinate, terinosis, and the blumia, which is the most common in our setup. There are other non-specific dust mites also which can come positive. Okay, and which will, by the newer method of component resolved diagnosis, we can diagnose it, but they are not of any much clinical significance.
In the history, it was written that it is exacerbated in the rainy season. Then during the rainy season, house dust mite population goes up, molds go up, and even in the pits, they are also not bathed properly, and there is a single entity.
So we'll come back to this. We will come back to the report. So next question to Dr. Sanjupta is, Dr. Arif has just mentioned about a word called component resolved diagnostic. Would you like to highlight a little bit about it?
Now this is a very important point. I do a lot of component resolved diagnosis, and that's a new block in town, okay? Now, as far as aeroallergies are concerned, CRD has not much role. It is very useful for food allergies, especially in cases of, if you want to diagnose whether the child is going to develop anaphylaxis or outgrow the allergy or will develop a severe reaction or not.
Dr. Sanjupta, your comments about CRD? Sorry, sir, but ma'am's comment about CRD?
Regarding component resolved diagnostics, I think there is less people working on this, so there are gray areas which I'll cover in few points. So for this case, if we consider this case, then there are certain issues that IgE is raised. As Dr. Vinayak has said, that if the IgE is extremely high, it means that there is polysensitization. And when there is polysensitization, there is something called cross-reactive carbohydrate determinants. And this is what then confounds the results of skin prick tests, also immunocap tests. That's where component resolved diagnostics come in. Suppose in this child, Rahul, we find that the child is allergic to house dust mite. And we also find that the child is allergic to shrimp. Now, these are the 2 things that share a common protein known as tropomyosin. If you're going to do component resolved diagnostics, the tropomyosin is broken down into the protein families. So you will know that this child is only sensitized to shrimp but is truly allergic to house dust mite. So you will come up with that information. Not only that, if this child supposedly is positive for house dust mite, in component resolved diagnostics, it will say whether it is positive to the DIRT-P1, DIRT-P10, DIRT-P23. These are the components of the proteins of house dust mite. And knowing that will let us know whether this child has the tendency of a persistent asthma, whether this child will respond to allergen immunotherapy, and what is the high risk factor. Common thing, this child probably will come to you and say, I want to keep the dog on my bed. Then if you do component resolved diagnostics, in spite of this child being polysensitized, it might tell you whether or not this child is sensitive to the dog. So if the child is not sensitive to the dog allergens because it will break down the allergens, then you can say, yes, the dog can still be on your bed.
Thank you, Dr. Ray. So for all those, let us try to simplify the things. So there are 3 types of in vitro testing, which my esteemed panelists have mentioned. One is total IgE, another is specific IgE, third is component resolved diagnostic, right? So I will try to simplify and try to, you can say, summarize everything. Total IgE, I have just told you that GARD is referring to any doctor. Any specialty, any doctor, total IgE. So it's a no test for allergies. Suppose if we know that we need a child to be examined, now going to the specific department, which is the pediatric department, that means it becomes specific IgE. So we know that, okay, which particular allergen we need to test, whether it is a dust mite, whether it is a cockroach, whether it is aspergillus, whether it is alternaria, whether it is certain pollen, that becomes specific IgE, okay? Most of the time, majority of the patients, when come to the pediatric department, they can be managed by a pediatrician because he is having a basic knowledge of MD pediatrics or DNB pediatrics he can manage. But sometimes there are few certain conditions in which he might require a super specialty referral. Super specialty referral means a child who is having refractory seizures, a child who is having refractory nephrotic syndrome, not responding, relapsing back. Then at that time he requires the super specialty knowledge. So same way, for an allergen, majority of the time specific IgE or skin prick test, they will do the trick. You need not to proceed further. But there are selective situations. Selective situation could be if there is a cross reactivity you mentioned about, if there is something else which is coming positive, like shrimp is coming positive, if the history is not matching with the symptoms, then at that particular time, or you are having a specific question with your mind, like for an example, peanut. So peanut is having different components from ERA H1 to ERA H13. There are certain components which are more allergenic, there are certain components which are lesser allergenic. You really want to know that which allergenic component the patient is suffering from and whether he requires EpiPen or not for the next possible anaphylaxis. So if you are having a specific question in your mind, then you will go with CRD. Otherwise, routinely, CRD is not needed. It is only needed in only a selected situations. So Dr. Mukesh,
just
coming. Yes,
just
ma'am,
one comment.
Yes.
Suppose you have a peanut allergy, as
Yeah.
you had mentioned. Some of the allergens are not heat stable, and some are. So depending on what component you are positive for, suppose you're positive for ERA H8 and peanut, and you can have the peanut in roasted form. So if you're positive for ERA H1 and H2, then it's different. So that way we can also counsel the patients depending on
Absolutely, absolutely. So definitely
Talking
you should
about
have a
allergic
specific
rhinitis
question.
out here now.
Sir.
Let's stick to aeroallergens.
Yes, absolutely. Dr.
For
Mukesh.
dog, just a moment. For dog, the CAN-F1, CAN-F2, CAN-F3, CAN-F4 are dispersed unevenly in different breeds. And if you are allergic to Labrador, you may not be allergic to pug. But in cases of cat allergy, if you are cat allergic to one breed, you are allergic to every
That's okay,
breed.
sir. That's okay. But for this forum, we are sticking only to the majority. Majority is like specific IgE or skin prick test that should do the trick. So, Dr. Mukesh, a quick comment about the eosinophil count. So, would you like to keep that or trace that or not?
We don't do the eosinophil count because there are so many regions of hypereosinophilia. So usually there is no role of eosinophil count.
So absolutely.
don't
So
do
if
that.
you have find, you can say like 7%, 8%. So don't consider it like a synonymous to allergy testing. Skin prick test, Dr. Arif, quickly, how it is done, what
But
reactions are seen, safe test or not?
eosinophilia, you can consider it as a poor man's pheno. If you don't have the pheno, you can just consider it as a poor man's.
Okay, right. Dr. Arif, sir, please.
Yeah. So the skin prick test is the last question is it usually against is the more effective than the specific IgE, and if you can get it done, you should do it. And everybody should learn how to be doing it because it's a very simple thing. You place a drop of the allergen and you prick. And since dust mites are so common and so common, you should always be looking for dust mites in your clinic. That's a very, very important thing, dust mites and cockroach. Because if you just start looking for these two things and all, you will find a lot of things positive, and you can advise good environmental control. So that's what I would say, that everybody should try doing it on an OPD basis, because it's a very safe test.
Thank you, thank you. So just want to once again summarize the thing. Comparison between specific IG, that is the blood testing, versus the skin prick testing. So the specific IG or the blood testing is actually testing the free IG, which are moving inside the circulation, whereas the skin prick testing is testing the bound IG, which is bound to the mast cell. I will give you an analogy. For an example, if I am interested in knowing how many people in this hall are wearing a white shirt, if I count, then there might be 10 or 15 people who are wearing a white shirt. So they all are single individual entity which are free floating, like a free IG or the specific IG, which is like 10, 12 people. If I put another caveat, that means how many people who are wearing the white shirt and sitting side by side together. Now if I see a pair of people who are wearing white shirt and sitting side by side together, that becomes skin prick test. So the skin prick test is considered to be more specific, whereas the blood testing or the specific IG is more sensitive. The negative predictive value is better with the specific IG, positive predictive value is better with the skin prick test. So these are the skin prick test results, sir, for this particular child. Valid test, house dust mite you rightly mentioned, it's 7 into 7, cockroach is positive, holopetelia is there, and dog is there. So what you would like to do next?
Yeah, so definitely, since there's an early morning sneeze, I would definitely think there is this house dust mite is very significant. And in the house dust mite, I would also further like to know which type of dust mite was this, because you have the three different important common ones, terinosis, farina, and blumia, which have to be looked at specifically, not just HDM. Cockroach, yes, is common. Yes, it's significant. You should go about it. Dog, yes, because he sleeps with a child. Now this holopetelia, that is a pollen, and your history does not match with this thing, positivity.
Brilliant point, sir. Brilliant point. So I totally agree with sir that dust mite and cockroach, this seems to be most culprit, and dog is positive and child is also having dog. So now here, first of all, I would like to little bit add on about the dust mite. What is dust mite? So dust mite is basically a small insect. It's a misnomer which called as a dust mite. It's actually a mite. Its actual name is house mite. So it's a mite. The diameter of the human hair is 50 to 70 microns, and the dust mite is of the size of 150 micron. So it is double the size of human hair diameter. You cannot see it with the naked eye. Where it is there everywhere, even in this carpet also. Even it on the chair where you are sitting, thousands of dust mite which are roaming around, we cannot see it, right? What is there in the dust mite? Why it is so allergenic? Dust mite, why it is born? It is only born to eat. It is a voracious eater. During the life cycle, it only eats and eats. What it eats? It eats the denders, it eats the hair cells, it eats all those things which are, you can say, like falling down, and then it eats. When it eats, it poops. Goes in, comes out, goes in, comes out. So the poop of the dust mite is of the size of 10 micron. What is this 10 micron? This 10 micron is PM10 particle. When this PM10 particle is going in, then at that time you are having this nose problem. So the nose problem, the rhinitis problems are majority because of the dust mite, whereas the cockroach dender is actually having much smaller allergen, smaller size. So asthma, the cockroach allergens or denders are more asthmagenic. Dust mite is causing more rhinitis type of the things, right? Now dust mite requires humidity and heat. So this type of environment which is there. So this is the ideal environment for the dust mite, and that holds true now the avoidance, how to go about the avoidance. So we usually prescribe them some certain sort of, you can say, like barrier covers, bed sheets, which are having sizes less than 10 micron pore, so that the poop doesn't, you can say, like cross, or the allergenic component doesn't cross the beds. Then we always prescribe them about the sunlight and many other different exposures, different things, and then definitely comes the role of immunotherapy. When you are deciding about immunotherapy, sir is right, that which species of dust mite which need to be. So Dr. Mukesh, chest X-ray, soft tissue neck, X-ray, PNS in this particular child. What is your comment?
So chest X-ray is normal in majority of cases of asthma, unless there is a long-standing uncontrolled asthma. So there would be normal chest X-ray in this case. If you look at the X-ray, ST and lateral view, very difficult to get the correct posture for adenoids. Basically, we are looking for the adenoids, since the child is having allergic rhinitis symptoms. But we don't know whether there is snoring or mouth breathing. For whatever reason, STN is not the first choice. If we want to document the adenoid hypertrophy, nasopharyngeal endoscopy is first choice. If you don't have that facility, then perhaps just to document you can get it done. But other problem is that even when you don't document adenoid hypertrophy in X-ray chest, there could be functional obstruction rather than anatomical obstruction. So even without having adenoid hypertrophy in X-ray STN, you may have functional obstruction. And third thing, in the X-ray PNS, again to document sinusitis, sensitivity is little bit better, like 70 to 80%, but specificity is poor. So even if we want to document the sinusitis, X-ray PNS is not the good choice.
So brilliantly said. That means with this particular given history or this particular case, none of these investigations are needed or required. They are usually needed just to rule out certain other differentials which you are thinking about, but majority of the time it doesn't help you. So Dr. Sanjukta, spirometry findings expected?
In this patient, we'll expect obstructive findings.
Obstructive airway disease.
And in obstructive findings, the first thing, usually a spirometry report is busy. FV1, FVC
So interpretation, I think everybody knows, so we are not going in detail. We are going a little bit further there. Suppose if the child is unable to do, you can say, Dr. Mukesh, spirometry is a small child, just unable to do. Dr. Mukesh, is there any other tool which you can use?
So when children are not able to perform spirometry because of the effort problem, we can do impulse oscillometry or the FOT technique.
And how it is different from spirometry?
In spirometry, we measure the flow volume curves, while in this we measure the tidal volume, and in resistance to airflow, we look at resistance and capacitance. So this is tidal breathing, which can be done in children above 2.5 years of age. So those children who are not able to perform spirometry due to the effort, we can do between 2.5 to 7 years of age. It is very...
Absolutely. So two major differences. One, it can be done at tidal breathing. You don't require a forceful effort. And second thing, it is much more sensitive for the smaller airways as compared to other thing. Dr. Arif sir, any role of nasal provocation test or methacholine challenge test in routine practice?
Well, I've never ever come across these things. These are more maybe being done in research settings. The other thing about this nasal provocation test, the standardization of the allergen exposure that you're going to do, because 5% of your allergic rhinitis may have a normal specific IG and a normal skin prick test, so that may come positive on this. But then how much of the allergens you should be exposed to is very, very important, because all of us in this room, when we are exposed to more than 20 micrograms per gram of dust, we'll all start sneezing. So standardizing of the exposed allergen is very, very important.
So in routine OPD practice, no rule. So Dr. Sanjukta, can you briefly outline the treatment plan for Rahul and what treatment goals we want to achieve?
Obviously, we'll go for inhalers, and we have to explain all the counseling has to be done. And treatment goals, obviously, cough-free days or cough that is not disturbing his school attendance, not disturbing his sleep, not disturbing his general day-to-day activity. And obviously, we will also have to talk about environmental measures to be for the treatment plan to be effective. And we need regular follow-ups. Also, we have to make sure that the inhaler technique use is correct.
Absolutely, brilliant point. So not only pharmacotherapy, it's like a generalized everything. So here it is everything which is there, and don't forget obesity, as it was mentioned earlier on. So Rahul was started on inhaled steroid. After 3 months, still there was no relief. What could be the possibilities, and what next can be done, Dr. Sanjukta?
The possibilities is that he is not using the inhalers in the correct
Yes,
way.
technique.
The environmental measures that we have suggested are not being
Not
followed
implemented. Yes, absolutely.
And simple things like even the spacer device is often not.
Yes, so all these things need to be corrected. So, and can pheno estimation help?
Pheno estimation very quickly has can help, because it has a predictive value, whether if high pheno also predicts a response to inhaled corticosteroids. It also indicates whether or not this child has been using the inhaled corticosteroids on a regular basis.
Perfect, yes. So pheno can definitely help. So pheno is basically telling you about the eosinophilic pathway or a use of IL-5 interleukin. So it can help that whether the child is likely to be responding to inhaled steroids or not. And second thing, if needed, if pheno is high, then you can even think about biologics, not in this particular age, but I'm telling in general that pheno, if it is high, then you can even think about biologics like IL-5 blockers like mapelizumab. So Dr. Arif sir, coming to you, I think this is the last question. Is Rahul the right candidate for immunotherapy? If yes, why?
Yeah, this is the most important thing, and the most important take-home message is that immunotherapy is the definitive cure for allergic rhinitis. And in this case, this patient should go on immunotherapy. Now, which immunotherapy should he be going on is because, see, there are two important things. What the international recommendations, they say that you should, they recommend for pollen and for dust mites. These are the two important ones. For the others, it's not been standardized. So this patient should go on immunotherapy for dust mites. That's one. The dog is If the child, there are various measures by which the dog can be taken care of that we are not discussing. But for immunotherapy, we have two, the subcutaneous and the drops. Which one to take? This child, since the FEE1 is more than 70% with treatment, can go for skit, and that is what it is will show a good response to it. The other point which I want to give to the audience is that in our country, we do not have any standardized availability of this allergens kit or slit. But if
That's, I think, sir, another area of debate, so we will leave it for there only. So, Dr. Panagra, can you quickly give some 1 or 2 comments about the entire case and summarize everything?
Hello.
Nice
Sir,
presentation.
can we conclude in half a minute?
Yeah,
30
we are
seconds
concluding.
more,
This is
please.
the last one.
Thank you everybody for nice presentation. So far this case is concerned, as we come across every day, the history is very important. Even the toilet condition in the school or there is that the weeds in the school environment is very common. We should ask also the internal environment, like any leakage in the room is very important. And after getting that, spirometry is a machine-driven, iOS is a machine-driven, spirometry is a patient-driven. So iOS has a very good result. And number 3 is coming to the last part, immunotherapy. The immunotherapy was started. If it is actually required, that said the components of diagnosis.
Thank you.
If
Thank you, sir. I think-
DALP2 is positive, the immunotherapy is good.
I think
Just
what
one
you
comment,
summarized-
we
Thank
do
you. Yeah.
immunotherapy after controlling asthma. In uncontrolled asthma, we don't start the immunotherapy.
Absolutely, yeah.
more than 70%.
So I would like to thank my co-panelists and as well as Dr. Panagra, who is expert discussant here, and thank you to the organizers once again.